Good evening, everyone, and thank you for attending tonight's conversation. My name is Ursad Malik, and I'm the digital content curator at the Stuart Hall Foundation. And I'm so pleased to welcome you all to the latest installment of the SHF's Reconstruction Work Program. Stuart Hall discussed Reconstruction as an opportunity to reinscribe the past, reactivate it, relocate it, and resignify it, in order to work through the present, reinterpret the future, and to imagine something else. Our Reconstruction Work series implements Hall's thinking through a series of online public conversations where we invite writers, artists, and activists to critically consider how we can build a better society in response to the COVID-19 crisis and the Black Lives Matter protests worldwide. In this Reconstruction Work event, we discuss how we can make sense of the concept of care in today's political and economic landscape. After 12 years of austerity, large-scale public funding cuts to education, state support for low-income communities, and essential healthcare services have all led to a crisis of care, a crisis thrown into sharp relief by the COVID-19 pandemic and the structural inequalities it continues to amplify. In this event, Dharmi Kapadia, who led on the recent NHS Race and Health Observatory report on ethnic inequalities in healthcare, and Dzifa Afonu, artist and clinical psychologist, will reflect on the concept of care in relation to austerity, institutional inequalities, and the ways communities have built and are building networks of care in response. Dr. Dharmi Kapadia is a lecturer in sociology at the University of Manchester and a member of the ESRC Centre of Dynamic Ethnicity, CODE. Her research focuses on racism, health, mental health, and older people. She works with the Synergy Collaborative Center and is co-investigator on the Ethnic Inequalities in Later Life project funded by the Nuffield Foundation. She was a member of the editorial board for the CODE Dynamics of Diversity census briefings and co-author of 2 briefings on ethnic inequalities in unemployment. She was principal investigator on a project funded by the Joseph Rowntree Foundation, exploring the links between social networks, poverty, and ethnicity. Dzifa describes themselves as a seeker, dreamer, and creative spirit. A clinical psychologist by training, they bring a decolonizing and deconstructing energy to the field of mental health and well-being. They are also a self-taught artist, fascinated with the art of everyday life, the creative nature of the human mind, and communication through image, color, and metaphor. They are dedicated to supporting those in frontline work with marginalized people. With over 20 years of experience in activism and 10 years experience working in the NHS, they bring a personal insight into the possibilities, limitations, and places for growth in both institutional and grassroots organizing systems. Their work explores ways we can bridge the gaps between work and play, and grapples with finding new ways of building community and supporting leadership that challenges grind or burnout culture and creates opportunities for real freedom. This event was produced in partnership with CODE, the Center of Dynamics of Ethnicity. The center, the CODE is an ESRC-funded research center providing theoretically informed, empirically grounded, and policy-relevant research on ethnic inequalities in the UK. They bring together expertise from a range of disciplines, including sociology, demography, economics, history, geography, political science, cultural studies, and seek to communicate their research to a wide range of audiences. And live captions are available by clicking the CC button in the Zoom bar, and the audience Q&A will take place after the discussion. So please submit questions or comments using the Q&A box at any point during the event, and we will try to answer as many as we can at the end. Thank you all so much for coming and for taking time out of your evenings to join us in what I'm sure will be a brilliant conversation by 2 brilliant panelists. And without further delay, I'm thrilled to welcome Dharmi and Dzifa to begin their conversation. Thank you.
Thanks a lot, Ursad, and thanks a lot to the Stuart Hall Foundation for hosting this event. And hi, Dzifa. So hi. We're in the spotlight now. We've got to keep this conversation going for about the next 50 minutes or so. So I thought I'd just start off by just saying a little bit about the NHS Race and Health Observatory report, which was kind of the basis for thinking about putting this event together. So I wrote this report with colleagues at the University of Manchester, the University of Sheffield and the University of Sussex, and the whole point of the report was to review the past 10 years of evidence that we have that shows ethnic inequalities in certain aspects of healthcare. So we focused on mental health care, maternal health care, neonatal health care, inequalities in digital access, so digital appointments, something that's become kind of much more sharply in focus due to the COVID-19 pandemic. Inequalities in precision medicine, which is the use of genomic medicine and genetic testing, and inequalities in the NHS workforce, so inequalities experienced by NHS staff. So that's quite a lot of areas, quite a lot of things that we might want to pick up on, or you might want to ask me about, Dzifa. And the report found really widespread inequalities, so lots of inequalities for ethnic minority people in accessing services, in the experience of the services and the outcome as well. So one of the major things, and one of the starkest things that the report found, was the amount of kind of racial abuse that patients reported, and how that actually stopped them from seeking out help from the NHS, which is a statutory service. And there was lots of other things that the report found as well, and we made a number of recommendations, and it's been picked up by quite a few different kind of media outlets, by people who work in the area. And just like on a personal note, I've had like emails from people who work in the NHS saying, thanks for the report, this speaks to my experience working as a doctor in the NHS, or people who have experienced these kinds of inequalities themselves as patients as well. So although the report itself may not actually, it's nothing new in the sense that, it was a review of existing evidence, and people who work in the area, Dzifa, you've worked in the NHS, people are aware of these inequalities. But I suppose the NHS Race and Health Observatory wanted to ensure that this was kind of out there, especially because we had reports last year, such as the Sewell report, which actually denied that institutional racism exists in this country, whereas the report we wrote was very firmly saying, yes, it does exist, and this is how it is affecting people in the receipt of care. So I don't know if you want to say a little bit, Dzifa, about what you thought of the report as someone who's worked in the NHS, and also just as kind of as an activist in the broad area of campaigning for racial equality.
Yeah, thanks. I mean, I guess maybe some similar things to some of the responses that you got. And I think when especially actually while I was training, I was really interested in, the evidence around racial discrimination, on both sides in the NHS, both for workers and for people who are receiving healthcare services. And the thing that I found, particularly startling to me, was this sense of repetition, doing this, finding out, going and doing this research to find out about the inequality, which then is shown, and then there's a commitment or advice to kind of do something to challenge it, and then a few years later another report comes out to say the same. So I've been really fascinated by that process, and yeah, I have been thinking about how we hold both the need to name and uncover and shine light on what the problem is, but also to think about how we stop this repetition, and how we, I wondered for you, after doing that, because one of the things I thought about the report that was great about it was that I identified actually a lot of holes in the research, in terms of areas where there weren't figures because there wasn't appropriate ethnic monitoring. And I wondered, like, if you were to kind of, I don't know what it would be. I don't know whether you have an idea of like finding a piece of research that might stop the repetition. Like, what would be the evidence that would stop it? Or is it not the evidence that is the thing that stops it? Like, where do you feel in terms of that?
Yeah, it's an interesting point, isn't it, about the repetition of similar findings from reports, maybe in different areas, some in health, some maybe in other areas, and then the same kinds of recommendations. So, the recommendations that we put forward in the report to ensure that, for example, one of the recommendations is make sure everyone's ethnicity is recorded in every single interaction within an NHS service, whether that's with your GP or whether it's in the outpatient clinic for physio. And to me and you, that might seem quite a reasonable thing to suggest, and something that should be manageable by the Department of Health or people working in NHS Trust. But I'm sure that recommendation has been made numerous times in the past. So it is an interesting question as to what can make that change. And I think, obviously, our political landscape is a specific way now. And I think, racial inequalities in healthcare have been given more attention than they have been in the past because of the disproportionate number of ethnic minority people dying of COVID-19. So there is more of a spotlight on ethnic minority people's health. But the pessimist in me thinks, is that still enough of a spotlight for us to see things change and for things to change meaningfully? So, for there to be like proper resources put towards saying, yeah, we're going to have like a proper strategy, by the Department of Health to ensure that we've got these targets, that there aren't these ethnic inequalities in all these different areas. So not just in one area of healthcare, but in lots of different areas. And I think it's obviously that the idealism that I have sometimes that there should be like a national race equality strategy for health and lots of other areas. I don't think that really goes away. That idealism hasn't gone away, but I think the realist in me thinks, will we actually see that? But I think we should still be campaigning for that because, as you said, the report's shown that, we have all this evidence. And then where we don't have evidence, it's still things that, we could improve it, for example, the ethnic monitoring. So also, I think it's quite hard sometimes as either a researcher or someone working in the NHS. We're seen as people who are very critical. So, I also had some emails saying, maybe this report, it's just going to enable the privatisation of the NHS because of what you've written. And that's really not the point of what the report was. The report was to say, we have this health service, it should be equitable for all, and these are the areas where it's not. So I think it's sometimes you occupy a difficult position. I don't know if you felt this, Dzifa, as someone who is advocating for racial inequality in healthcare or for workers or whatever it may be. In doing that, you're seen as a critical voice of something that's seen as it is a national treasure, the NHS. So I don't know how you felt when you've worked for the NHS or since leaving the NHS.
Yeah, there's two things I wanted to think of, to talk about. One was like, I think actually sometimes I think like the focus is often on like the speaker and not on the listener in relation to this thing. So the speaker maybe are people like you and me who vocalize and become the critical voice around the NHS and healthcare and racial inequality. But there's sometimes not a concentration on the listener, and why it is that the listener doesn't act after hearing the news, that, you know, like, that this is still happening. Here are some simple steps you could take today that can make a massive difference. But what happens in the process of listening, or the translation, what happens after the research, I think is like an interesting thing to like consider. I think actually personally for me, I feel like I sit in two places where I hold the version of myself that was inside of the NHS and wanted to make it different from the inside. And I hold that part of myself with a lot of compassion and understanding. And I don't think it's because I've moved out of the NHS, or I think we tend to think of ourselves as in progress. So the things that we used to believe and the things that we now believe are somehow different. And my now position is somehow better than my previous position. And I don't feel like that in terms of this issue. I guess I have I do strongly and deeply care for all the people who are working in NHS services trying to make a difference. I know them, and I've met with them, and I've cared for them, and they've cared for me. And we've got through hard times together in working in the NHS and dealing with this stuff and thinking about this stuff and talking about this stuff on a daily basis. And I think that work is critical. And even in a failing NHS, there are little pockets of success and little pockets of ways of being and ways of challenging and resisting some of the stuff that is actually successful and has a potential for being some of the seeds of change that we could have in the NHS. That's why on my optimistic side. But there's also a part of me that has left the NHS and has also left it in terms of wondering whether we can fix it. And I don't know. I don't know the answer, honestly. And I don't want to have that answer because, like you say, there's that risk. If we say the NHS is broken and cannot be fixed, then the alternative must be private healthcare. And I really hope that that isn't the only. I hope it doesn't have to be polarized like this. I hope there might be something else that we might be able to build on some of the things that are already existing, some of the ways in which communities are already organizing and creating community spaces that have democracy and also really address power and investigate and connect really with the people who need the health services most. I have an optimism for both sides, and I wonder, I don't know if we can. I don't know the answer. Can we live without an NHS and have an alternative? Is that possible? I don't know, but maybe in the meantime, wherever we are, it's like being able to hold both of those things at the same time. How do we hold that improving the NHS and putting energy into that can still be of use and still be of benefit to many, many people's lives, while at the same time, those of us who are outside the NHS can also start creating and being inventive about new ways and different ways of organising and thinking about healthcare in general. And not that has to be a divide, because those people interchange and are the same people very often. I was the same person. I was still an activist, and I was working in the NHS. I was an equalities officer. And I was also, thinking theoretically about, race and racism and whiteness in areas where it was safer to have those kind of conversations. So we don't exist necessarily separately from those places. But I wondered, like, whether you have any of those dilemmas in some ways about the report and wanting. I guess the greatest hopes for the report is that it might make a difference to improve the NHS, and that there's also like a loyalty to the public health service and the ideals of it. But is there any conflict for you in that?
Yeah, I suppose I feel less of a conflict because I've never worked for the NHS, so I kind of always sat outside it. But I like you, I am an advocate of the NHS, so the report really is just for how can we make it better, and like you, can we make it better, and will it survive? Which I also agree with you. I want it to. I just wanted to pick up what you said about kind of the organising and the services that are provided by kind of local communities. So I think during the pandemic, with some of the other work I've done as well, you know, there's been a massive effort by people working in these some small grassroots organisations to ensure that people in their local area are provided for. So whether that be in terms of making sure people have a hot meal, people who are not isolated, or people who've been bereaved, they can access some kind of counselling or bereavement support. So kind of all this is, a lot of this has been done by small ethnic minority-led organisations. And I think in the report, well, we kind of touched on it a little bit, but not to the extent that we might have been able to. But the fact that some people are accessing kind of, you know, some kind of health services, especially kind of mental health services within these kinds of organisations, because for some people there is a real lack of trust to go to an NHS service, and they feel much more comfortable with these smaller organisations. But I think one thing that I've kind of thought for a very long time is that a lot of these smaller organisations are not very well funded, or if they are funded, they're funded on like a really short-term basis. And this happened during kind of over the last 2 years as well, you know, small pots of being money given out to people so that they could do, you know, some grief counselling, but on a very short-term basis. So I think, you know, there is a lot of work to be done between kind of the NHS and different parts of the NHS, and a lot of these small community organisations, some which are not that small, some which are larger as well, who are doing a lot of work with ethnic minority people to say, you know, how, and I'm not suggesting that they should all come together and be one big service, but, you know, why can't someone be given like a 5-year funding contract or a 10-year funding contract to say, oh, so you're providing services in this area, you know, we kind of contract you to do that. And that also relates to the point of, you know, if the NHS and some of these organisations could come together to think about how you could build better kind of trust with some ethnic minority groups, then surely that's beneficial to the NHS and to the people accessing the services. But I think, and obviously that I think it's a good thing that people can access services from, you know, smaller organisations that they trust, but people shouldn't feel like they have to go to those places because they can't get what they need from the NHS. So, you know, we often talk about like mainstream services being NHS and then, you know, kind of voluntary organisations being outside of the NHS. But why can't there be better integration of the two so that people are getting the same kind of equity of service with the same resources back being provided to those organisations that are giving those services? So, and I think that's something that there needs to be more commitment from, you know, from kind of like Department of Health and people making those kinds of decisions. I don't know if you've had like when you've worked with lots of organisations, I don't know how if you have like a similar thought to that, or you've got a different idea about how that might work.
Yeah, I think I've always been a massive advocate of the work that's been done in the voluntary sector, because that's where I started my kind of working life, and I saw this complete like excellence in terms of the practitioners, from youth services to you know, projects in working in schools, thinking about mental health and thinking about all sorts of, you know, there's just many multiple communities that, and you know, once we like expand healthcare to beyond just, you know, going to your doctor because you've got some symptoms, and it's also about you know, our housing situations, it's also about our access to resources, it's also about trauma in our families. And so in terms of services, you know, there's just numerous services. But I think I've been, especially with what's happened with COVID, I think I've been really questioning the issue around trust and the way in which many ethnic minority groups in I actually hate the word ethnic minorities as well. Ethnic majority or world majorities. But yeah, you know, whether people actually trust the NHS, and with what's happened with COVID, and just I think the government as an extension of the NHS, that there is a lack of trust, and that is a trust that has been broken over many years, with many examples. So we can look at it on these multiple levels. We can see how the trust was broken on a governmental level in terms of what our politicians have been doing. And then we can see how our trust gets broken in terms of the services and the services that get cut. But then we also have our own individual experiences of the health services and the kind of pain that's come from going to a health service for support and realizing that you're being dismissed mostly because you're not seen as the kind of person that's worth listening to, due to the race that you're coming from. And I think that element of trust needs to be really addressed before we move towards like merging the voluntary sector and the NHS, because what the voluntary sector has is some of that trust, as many of the voluntary sector organizations are actually people who have got personal experience and personal connection. I think many of the people in the NHS are also those people. They're people who have personal connections, but there's something about the institutional structure of those organizations that sometimes actually dissociates us from those experiences. Like from my experience of being a clinician, it was very hard to talk about, you know, my own personal experiences of health services and my own. And I'm thinking about a client who is, you know, anxious and doesn't want to go to see anybody. Maybe I'm supposed to do an assessment with a young person who doesn't say anything. And I completely empathize with them. They've been talked to many times by people who failed to understand them or listen to them. They've seen their families also been dismissed. Maybe they even know about some of the research that says the outcomes for Black and brown people are really negative. So I think there's an important step that needs to be about this trust rebuilding. And I think, you know, one of the things about these potential researchers, the research that you're doing and many others have done, is that what I would like the outcome to be is that the listeners are able to like confront the reality of racism. And that would be the first step for many people to like really actually say, man, this is a mess. Like, let's really look at this. And to be able to start rebuilding that trust requires like some authenticity and a willingness to really look at what the problem is and not to keep on turning away. But I also think there are institutional policies that make it very difficult for people to trust the NHS. And so, yeah, my fear about voluntary services partnering with the NHS, although there's some benefits, is that you potentially are bringing that distrust into a service that has some trust. And that is a complicated, so when we do go into those, when there are partnerships between the NHS services and voluntary service organisations, the people doing that partnership work and doing really also have to have an awareness and a willingness to actually kind of confront and face like the mess that the NHS has made of trying to tackle the racial inequalities in healthcare for many years. Not just that, but the historical impacts that much of the health service over many years has contributed to the oppression of Black and brown people and other people who are also minoritized in our society.
Yeah, I think that's right. That is the massive risk of any kind of partnership working. But it is, like you said, it is happening on local levels. So, you know, some of the work that we've done with the Synergy Collaborative Centre, which is the funding for that's finished. It's now going into kind of phase 2, where it's being run by NSUN and Catalyst for Change in Birmingham. And in the first phase of that, it was really trying to work with some commissioners or kind of leads within the NHS setting in certain cities to try and see where we could get that commitment. And, you know, it really needed some you needed people in the NHS who were really committed to saying, yes, this racial inequality exists. And for that project, it was about mental health services and really wanting to do something about it in their area. So, you know, that was happening in Leeds, Manchester, Birmingham, and one area of London as well. But the amount of work that it took to get to that stage and build those kinds of connections, and, you know, they had some existing, you know, good working relationships with the voluntary sector, with some groups in the voluntary sector as well. And then, you know, they've created jobs within the NHS, which is really specifically about tackling racial inequality within mental health services. So you can see the amount of work it takes to get to that stage, to build that trust, like you were saying, and then to actually make a, you know, a tangible commitment to doing something about it. And that's on a local scale. So if we wanted that to happen on a national scale, we're talking about years and years of work for that to happen. And, you know, if you want it to happen in a range of healthcare services for people, because as the report showed, you know, this is not, we only focused on a few areas, but, you know, the types of issues that were apparent, you know, people being dismissed by healthcare professionals, people not being listened to, people being racially stereotyped as to why they were coming, not getting the kind of service they wanted. That was apparent across the areas that we looked at. So I think that, and I think maybe that's where the small changes do give some kind of hope that it could happen. But I think then you think, well, if you live in that area, then you might get, you know, it might be a bit better for you because that area is committed to it. But where I live, you know, that's not happening. So what am I supposed to do? You know, things are not going to change for me. And that's also jarring for people, you know, that if we don't have a national commitment, we don't have a national strategy. And obviously there's problems with that too, because, you know, that things are never kind of resourced equally well geographically. But then people miss out on, well, they miss out on services and they miss out on that kind of commitment for services to be equal for whoever from any ethnic background. But I also think that, you know, in the process of doing research, we as researchers and the people that help us with the research, that participate in it or, you know, speak to us, you know, people think, well, why are you doing more research? We've already got loads that tells you about all these inequalities. So why do you keep doing it? Why don't you just get someone to do something about it? So then that's when you as a researcher think, well, yeah, I kind of agree with that, because we've done, there's been decades of research that shows inequalities within kind of not only in healthcare, but also in people's health. So in, you know, how healthy people are or the illnesses that they get, depending on which ethnic group they're in. But I do think that it is important to keep doing research to show the persistence of these inequalities. So, you know, the people who say, you know, well, we live in 2022 now, these kinds of things don't exist. Well, actually, no, and we can show the level of those as well. So we can show that actually, if you're from an ethnic minority background, you're still going to get a less good service from the NHS for certain things. You're still more likely to have poor health or poor mental health. So those things are still happening now. It's that we're not harking back to some, you know, some really old stats to show this. This is still happening now. But I think as well, in the last couple of years with the pandemic and us being able to talk to people online that we might not have done before as academics, activists, speakers, I think maybe these kinds of conversations are happening with more people now than they might. So not to say that, you know, as you were saying, I'm not saying the people that need to listen are definitely listening, but there might be something about kind of doing this kind of event or the online nature of some of our work, which might mean some of our messages are getting to people that they might not have done before. I'm not advocating for, you know, online work for everything, but I think that's one thing that I've seen. You know, I've spoken at events that maybe I've never even been invited to before, or might not get a chance to speak speak at. So yeah, I don't know if you've felt like that when in your work as well, Dzifa.
Yeah, I think it's been really, I don't know, I felt like it's been really interesting, especially after George Floyd's murder. There was quite a lot of, it reached into places that it had never reached before. It was the first time that I was feeling like the repetition wasn't quite the same. There was a different rhythm to it. And one of the things that I was really surprised by were the kind of conversations we were having inside the NHS. Over that time, I worked in 2 NHS services, and each of them created kind of spaces to discuss race. And for the first time, it wasn't just on a surface level, it was like deeply thinking about what it means to be white, what it means to be perpetuating racism, what it means to be a service with a history of racism, what it means to be so kind of anxious about racism that we can't really face it. And that was really optimistic. Unfortunately, I didn't stay to see if those conversations continue. But I do have, I've recently really been thinking, because I often used to get really despondent and cynical and miserable when things died down. But I also have started to think that some things are seeds, and you're not, you don't know the trees that will come from it. And there's still some hope in those moments, even if now those organizations are not necessarily talking about race in the way that they were. But that was, heads of services and across the board having much deeper conversations about race than I have seen previously. And I think that's a mixture of things, because COVID, I think it's the same thing for us about the war and in Ukraine, that there is also this sense that we are now touched more by what happens globally, and we've been living inside of this communal trauma for so long. Our nervous systems, and we're confronting those places, those so often in our own homes, that somehow that they reach further. I think that has positives and negatives, because sometimes it can be overwhelming and actually be really negative for our health, and we need to have kind of boundaries around it. But there is also something about the way that we're being touched by these things that is making a difference. And I wonder, yeah, I'm really curious about what's different. And I think that one of the things I remember, I can't remember specifically the quotes, I'm probably going to bastardize it, but Sarah Ahmed, who's a theorist at Goldsmiths, talked about kind of the work of race equalities work, and it was like, she described it as like kind of exposing the walls, and that sometimes the race equality officer for any organization or people creating research that identifies racial inequalities are the people that keep on visibilizing the wall, and that we do need the visibility. We need that some people to keep holding it visible, because I think there's a tendency for all of us as human beings to want to forget, especially pain, to actually want to move on. There's like it's almost like a traumatic response. It's a shut down. So when maybe there isn't just a lack of listening, maybe there's an overwhelm feeling for some people in positions of power that could maybe make more, yeah, maybe there's a sense of like, gosh, this is awful, this report, and all the fact that we're still failing on this issue is horrible, and I feel kind of ashamed and saddened by it. But then that feeling and that discomfort can't go anywhere, because it's stuck inside, and often even those in power feel powerless, and it's this complicated thing. I think I remember feeling like I felt like going into becoming a psychologist and to be able to use that power for people, to how much everybody feels powerless, even the people above. I'm not sure if that's a reality of what, you know, like if you're in a high position and you have the power to commission or not commission certain services, there is still more power than the person who's coming into the consultant room and is needing services. So I think it's a bit of an illusion to say that you have no power, but at the same time, there's something to be like paid attention to, the fact that people hear this work and feel like they have no power to make a change and no power to actually make it different for people. And I wonder whether, you know, some of those two dynamics are part of the reason that, you know, we end up repeating ourselves, and the research keeps coming out. But yeah, I think there's something about really trying to understand or exploring, you know, what happens in those repetitions. And yeah, when there's breaks in the repetition, why is that? Like, why is it that, you know, that you've had such a response with this report, and also the report that came out about COVID, the disproportionality effect of COVID on people from Black and brown communities, that was also met with like slightly different response and a wide reach. And so, yeah, I wonder also about, do you see some kind of difference in this research and the responses that you've had to it, and what do you think might be causing that, if there is a difference?
Yeah, I think that, so I think it's, this report's come out after many other reports, and not just research reports, but news reports, and people highlighting just how bad it's been for ethnic minority people in terms of how people are dying, how families have been affected. And not just like people dying, but how they've been affected in other ways, you know, how their jobs may have been decimated, gone away, how they've been racialized in the media, you know, being blamed for not wanting to get a vaccine. So they've been, you know, seen as irresponsible. So it's come on the back of all of that's been happening over the last couple of years. And obviously there's the whole history before that as well of how people have been treated. So I think maybe that's one reason. And the other reason is that maybe more people are now tuned in to the actual realities of racial health inequalities in a way that they haven't been before. So then when a report comes out like this, they're already kind of tuned into, this is something that now they may be interested in, whereas maybe, interested might be the wrong word, but maybe this is something that they didn't think was a major issue before. So, you know, this could go for people in policy, it could go for people in the media, or for people working in health organisations. But it's whether it can remain as something that is considered to be important. But I find, you know, in academic circles, I'm always hearing about someone else doing a piece of research about the effect of COVID on ethnic minority people. Or, you know, there was an event at the weekend led by academics called the Nurses Narrate Project, where they released a documentary about nurses' experiences of racism during the pandemic, and they'd interviewed lots of nurses. And sorry, I haven't watched the documentary yet, but it's on my kind of list to do. So, you know, I don't go a day or 2 days without hearing about someone else doing something in this area, more so than before, I feel. And, you know, people contacting me, not just about this report, but other work that I do as well. So that interest is coming from different areas. It's not just other academics. It's not just people writing a news story or people in a policy, or it's coming from lots of different areas. And I think what you were saying about doing that work of keeping it visible, keeping it important, keeping it in people's minds, that's the hard work, isn't it? To keep it there, and to keep saying, yes, this is important. Yes, this is what the data says. This is what people are telling us. And hope that somewhere there will be, you know, small movements in people's thinking, which then leads to some kind of action or to some kind of change. because when I started working in research, you know, I was very idealistic, and I thought all my research was going to change policy. You know, I was very young and pretty naive. So, but an element of that has kind of come back recently, thinking, oh, you know, maybe people really do, you know, want to do something about this, or certain people want to do something about this. Maybe in the future, you know, things could change. And that might actually sound like really silly, actually, given the type of kind of hardships that people have been facing in the past few years. Because, you know, people have been really struggling because of COVID, but also because of austerity, you know, all the cuts that have happened previous to the pandemic and further cuts that are happening, the increased cost of living, you know, all these things that do affect minoritized and marginalized groups more than other people. So I think, you know, it's a difficult kind of thing to say, oh yeah, maybe things will change, but actually no, up till now, what have we seen in the past 10 years? Not that much change really. But maybe it is on people's minds more, but I think, yeah, the key thing will be whether it stays on people's minds with those people with some kind of powers to wield change, and whether they will, because I think what you were saying about people in power feeling powerless, those people have to put their necks on the line as well, because they will be going against what people even above themselves actually want or believe. So yeah, I've just seen that there's some
questions or
yeah.
discussion. I was just going to actually come back to like a bit of, yeah, maybe some of the optimism as well, or I think it's like there's like holding both things, especially when I used to work inside of the NHS, was that it was trying to hold both the enormity and complexity of the issue and the multiple levels of context that people are facing, but also to like not completely dismiss those moments of like real connection and real resistance, like on the everyday level of what people's experience, you know, what people's experiences are. It goes a long way for, you know, an individual to go that step further for somebody, in order to actually support somebody through something, knowing that they are facing additional challenges because of the discrimination that they're facing, and maybe the history of their experiences of health services in general, that, you know, those individuals that do stand up against, you know, perhaps stand up to power, take those risks, you know, do the resistance work, you know, that work is also really important, and those people really need resource and support. I think, you know, one of the things I really realized that can be so difficult is there becomes this like real division between the people who are giving healthcare and the people who are receiving it, but especially for people like me who have experienced like traumatic experiences as someone needing to use the healthcare service, and also has felt disempowered as a Black person working in a very white profession, that, you know, that the boundary between like me being this powerful professional who doesn't need any support and should support other people is just not as strong as it is, and there really needs to be a lot more support for those people who are willing to take a risk and are willing to make a difference, to actually have the support, so that they're not just doing it from complete exhaustion, which is what often happens. I think the NHS itself exists on exhaustion with the austerity and the cuts. You know, the very nature of the NHS, because of the way it's been destroyed, is about relying on people who are willing to go like way beyond what they're being paid for, way beyond what they're being supported to do. And many people do, because actually many people in the NHS deeply care. Many people are really offensive and abusive to patients, but also there are people who care. They are there, but they are also broken sometimes by the system that's also broken. And yeah, I think the NHS relies on people who are willing to kind of break themselves in order to meet the needs of the public health, because it is massively underfunded for what the actual task is at hand. And also it focuses on an emergency form of healthcare instead of thinking about healthcare more broadly. If we really want to improve the health outcomes for people, Black and brown people, what we really need to do is also change the ways in which they discriminated in multiple places. It's not just about when they have a consultation with the doctor, it's about the housing, it's about jobs, it's about violence, it's about their experiences of violence in the care system, their experiences of violence in the mental health system, their experience of violence in the police and correctional system. So I think, you know, there are, yeah, I guess that I feel like it's like how we hold both the complexity of the whole thing is so complex, and obviously to make it better, we want all of those elements at every level to be solved, but also those small moments, we give those like a higher, like we appreciate them more highly than those small interactions, those small acts of resistance as something important to be considered and to be supported.
Yeah, I completely agree. You know, we have to have this idealistic picture of how we want things to change in these massive institutions like the NHS or the education system or the police, but we have to highlight and pinpoint those acts of resistance as well, so that people see things can be possible. I just wanted to pick up on kind of a couple of things that are being said in the chat. So I think Talika mentioned, you know, picked up on your point, Dzifa, about visibilizing the wall, and, you know, kind of mentioning that that's actually really, it's a lot of work for people, and the people that are doing it are often those who are from minoritized communities or who have more to lose, and they're taking on this extra labor. So this is something that I've seen time and time again. So not just in the NHS, but in other organizations. So, you know, a friend of mine or someone's telling me, oh, you know, I'm going to be the race equality lead here, or I'm going to take on being the lead for the staff BME network, or whatever it might be called. And obviously that work needs to be done, but at the same time I'm thinking, do you really want to do that on top of all the other things that you already do in your organization on top of your actual job? And why is it that someone is approaching you to do that? You know, and there's very good reasons, you know, why people are approached or why people think people might be good for it. But, you know, there needs to be the wider commitment within workplaces. First, to recognise that work that is done, and that should be taken out of your workload. Sorry, that's like a very university term, but also getting support from other people. So, you know, people who may not be from a racially minoritized group, or to get more support from them to do that work, and to think about how racism affects people in your organization, and how it operates within the organization, to maintain inequality, basically. So I don't think there's a proper answer there, because the people doing that kind of work are very committed to it, and obviously they want to see some change. But I don't know, from my experience and from what people tell me, people do all of this work in an organisation, then they feel like they're butting their heads against brick walls because nothing changes, and they're still in the same situation as they were 10 years ago. So I think that's really difficult. And I think, you know, some people will say, you know, well, I did it, it's time to pass it on to somebody else now. And it is about protecting themselves as well in doing that kind of work. I don't know if there was, there's quite a few questions. I'm just trying to read through a few of them. So yeah, a couple of people mentioning that they did go to the Nurses Narrate event and the documentary screening that I mentioned. So thanks for your comments on that. And I can imagine that that was actually very heartbreaking to see, to think about the nurses working during the pandemic and the abuse that they've suffered. Is there any questions that you want to pick up on there, Dzifa? Because there's quite a few comments coming through from people in the chat box. I don't know if there's anything.
actually wanted to say a bit about the, the work of, Black and brown people in terms of doing the work of identifying the issues. And I really, I think it's just as important to be able to decide actually not to do that. But I think I want to be cautious of like it being kind of a polarized thing. Like there are people who choose to do that work and feel like they can and that they want to and they should do. And then there is also a need for us to look after ourselves and actually to kind of, for me, a lot of the attention of my thinking has gone towards like me and my healing of trauma, of racial trauma, and how do I actually address the ways in which racial trauma have impacted on me and my body and my family and my friends and how I am with others. And I think that having that space to kind of look inwards and take care of ourselves is also really an important choice that people can make. And if stepping away from those roles is something that helps, I can say, I feel like that's really important. I was looking at some of the questions. One was about training institutes and tackling inequalities. I think, having like gone through training in the NHS, there still feels like a massive gap for actually being able to address it. I guess for me, it's the similar things, like there's institutional ways in which the education systems themselves function to kind of perpetuate discrimination. They're very hierarchical. There are lots of power dynamics and competitive natures of things. People are put against each other to kind of compete for marks in some way, and there is a certain idea and understanding about what it means to be a professional. There's certain understanding and belief about what it means to be an academic, and some of those belief systems uphold a kind of both a burnout kind of culture and the culture of denying racial difference and making it hard for people. I think a lot of institutions need to actually look at how they're treating the few, maybe more, it depends on what type of institution, people of colour that they do have in their services that they're actually like working with, because even at that level, those institutions are often headed by white, like most academic institutions that train professionals are headed by white staff, white board members, white lecturers, and the numbers of people of colour in those institutions are really low. So we actually have to also address that before we just kind of teach people how to address racial inequalities when they get into the workplace. We need to do it at all those levels. I don't know how you've experienced, like as an academic, whether you've had any experiences of those dynamics in the academy.
Yeah, so it's interesting when we think about training. So I think like a lot of people will have probably been on unconscious bias training because their organisation makes it mandatory. So in quite a lot of academic institutions, you have to take an online module on unconscious bias, which is supposed to, address racism in the institution. And I imagine there's other courses in other organisations, such as the NHS or, in education, where people who lead in these organisations think that providing a course is some way addressing the racism within their institution, where in fact they're just using that as a tick box exercise to say, well, we've provided this training, so, we've addressed racism. But really it's not. Obviously, maybe some of this training has a place, but the real commitment comes at ensuring that racism is addressed in all levels. So, do you have an ethnic minority pay gap? What, who are your board members, as you were saying, Dzifa? Where is the representation? Who's being promoted? This particularly applies in the NHS as well, where ethnic minority staff are less likely to, get promoted, be in these higher positions, earn lower than their white counterparts. So that, to me, is addressing racism in an institution. And I think the training that you provide for staff should bring these elements into it. And you should be honest with your staff and say, this is what's happening in our organisation, and these are the steps that we're taking to address it. Not provide an online quiz which tests your apparent unconscious biases, because how does that really help anyone, either the member of the staff or the organisation as a whole? So I think I'm very cynical about the training to date that has been provided. Obviously, I can only speak to it from my experience within academia. There may be some organisations that are actually doing this very well and taking a much more meaningful approach to it. But I think I'm quite cynical about thinking that the answer to addressing racism is through training courses for staff. I'm just going to have another quick look at the chat. Sorry, I find it really difficult to talk and look at the chat box at the same time. I'm not good at multitasking. So I think someone has asked if the arts can be used as a tool to kind of think about building trust between ethnic minority people and the NHS, or between kind of NHS and ethnic minority voluntary groups. So I think the arts is a very good way to engage people in some of these issues. So, not everybody wants to listen to me talk or somebody else talk about research or attend a webinar. The arts are a really powerful tool. And art can be in lots of different ways. It can be a poster at a tram stop, or it can be someone putting on a play. So I think there are ways that could definitely play a role. But I think that's also hard for artists as well to I don't know, kind of get that funding as well to do that kind of work. I know that there are, there's a couple of artists I know that who are kind of within that space of making sure that their art speaks to, well, because they want to, that's their work, speaking about kind of racial inequality. But then I don't know how well some of that sits with them to work necessarily with the NHS, or, kind of, they may also have had similar experiences of institutions and may not trust them. So obviously I can't speak for all artists, but that's another consideration for them as well, isn't it? In their work and how it's viewed.
Yeah, I think I guess as a kind of self-taught artist, and some I really have found it an incredibly powerful medium for healing and expression, and I think it gets very little really looked at. And I think that there are ways in which the art institution itself also has its own institutional things, and the way that we're taught art in school is this idea that actually we're not artists unless you have these certain credentials, but actually everybody's an artist, and everyone has something to say, and everyone has the opportunity, everyone has a way in which they can actually express themselves. I think we haven't talked lots about kind of some of the alternatives in terms of the details of some of the things that, in a lot of my work at the moment. I work in an organisation called Healing Justice London. We do a lot of work around both using art and thinking about embodiment practices, thinking about how we actually work with the nervous system. And I think art has a connection to be able to tap into certain parts of our kind of bodily and neural systems in a way that other practices don't. And I think those are also important. One of the questions we were discussing, we went to discuss today about alternatives to the healthcare system. And I think that there are movements towards methods of healing and actually things that can be preventative of healthcare. If we can actually reduce our stress levels through yoga, meditation, art, mindfulness art, all of these kind of mechanisms that more and more people have been interested in it over the period of COVID, partly because we've all been at home with ourselves, and online access to those practices has been much greater. And it's a shame that the NHS hasn't integrated many of that work. Some of the work that I've done with Healing Justice London has been around the Resilience Toolkit, which was being put together by NCAM. I wish I had like full details to pass on to people, but if anybody wants to know more, please do get in touch. But she's been doing a lot of work. She's an ex-nurse, and she's been doing a lot of work around kind of trauma and the impact of trauma on people's bodies, and thinking about how we can kind of actually help our bodies to regulate better or be more in tune with our bodies, as a way to actually improve our health outcomes. I think some of those things that are a bit outside the box of healthcare services can also be part of the conversation about how we improve healthcare services for people.
Yeah, and I think the way you've described it is the way that like people kind of want that to be an option. So, you know, if I want to kind of do those kinds of things to look after myself, and I do that in my own private space or sphere, that's great. But I think sometimes, well, within a university setting anyway, and I can imagine this is the same in the NHS as well, is when employers kind of want us to do these things as though that is you know, the solution to all the things that we're facing at work, then that's when it's really jarring as to actually, no, I don't want these free courses. I want something different. I want you to commit to, you know, changing working practices, or I want you to commit to racial equality in my workplace. And I think what you've said is really important, is that people do want to look after themselves, but they don't want to be told that necessarily by their employer. They want their employers to play a different role.
Yeah.
You know,
I guess like the reason we talk about healing justice is because we're actually pulling together those two things. We want to be healing and be resilient against the traumas of institutional oppression, but we also want to change the systems themselves that are causing it. So it's that we hold both of those things, and I think that that's what employers fail to do when they send someone on a mindfulness course to help with stress when they're stressed out. It's like, well, let's ask the question about what's causing the stress, and let's see if we can find new ways of structuring our services that don't cause people to have stress, because it's never going to be that one employer that says I'm stressed and then gets sent on the mindfulness course. It's probably one of many, and others are just keeping silent because they don't want to be sent on the mindfulness course. I thought we just have like a few minutes left, and there's one more question I was just trying to read. One about such a brilliant conversation. Feel the mental health services need to be blended, publicly funded, with some local community services being delivered by small organisations, and because structural discrimination and racism has been baked in over years and decades. Can't wait to be treated well. Would mandates for mentoring to senior leadership, strategy and policy making positions for ethnic minority staff enable and encourage these currently white dominated positions of power and influence to become equitable and representative?
Shall I go on that one first, Dzifa? Yeah. So I think that there's definitely a place for mentoring schemes within the NHS, and I'm sure, sorry, I'm not up to speed on all the different types of schemes that are available for staff. So obviously these have a place for, you know, ensuring that kind of promotion is equitable, people have opportunities. But when I spoke to some people in the production of the report, so we spoke to some kind of stakeholders, so people with experience in the field of kind of inequalities in the NHS workforce, for example, And even those mentoring schemes, the people that get selected for them, you know, there's a bias in that. And the people that get picked from an ethnic minority background to be put into that leadership position or to be put into that managerial position, that is all that can be, you know, carefully selected. So I think there's definitely a place for mentoring schemes. And, you know, I would really encourage kind of mentoring schemes in lots of workplaces to give people opportunities to get access to information that enables them to progress in their job roles. But that's kind of one small part of the whole kind of solution to this big problem that we have. I think that's where I'd be coming at it from. I don't know if you want to have the kind of final say on that, Dzifa, before we kind of timed up.
So 1 minute to go. Yeah, I think for me that a lot of the issues for, I think, like Black and brown people that end up being put into positions of leadership within the NHS is that there's a sense of like having to kind of toe the line. The more that you go up, the less that you can be vocal about the issues. And so that's kind of off-putting for a lot of people to get into those positions and find themselves like isolated in those positions trying to fight for differences. So I think the idea of like these mentoring courses that someone does for a few weeks is not really the same as actually having mentoring from others who are in leadership positions and have managed to keep true to their, you know, true to their politics and true to the things that matter to them in those positions of power, but also to have, you know, like almost having elders that could actually support those people in those roles. I think would be, you know, actually a better way of doing it, that actually does, you know, genuinely address the fact that it can feel like you are more silenced the higher up you are because your position is so tenuous as someone from a minoritized group.
Yeah, thanks a lot, Dzifa. And I think, you know, we've come to the end of our time. So thanks a lot, Dzifa, for kind of having this chat with me. And I hope that people kind of enjoyed this, and please get in touch with Dzifa or I or the Stuart Hall Foundation to kind of follow up on anything. The recording will be available on YouTube as well if you want to catch up or want to share it with other people. And thanks to all our audience as well for the really pertinent comments and the interesting questions as well. And I'm sorry we weren't able to kind of speak to all of them, but please do follow up with us if you want to kind of talk further as well. So thank you very much, everybody. Thank you for listening and enjoy the rest of your evening. Thank you.
Thank you. Thank you both so much for such a warm and thoughtful and critical conversation. So many brilliant ideas, and I could see in the chat that, you know, everyone was really receptive, and thank you all for your questions as well. Thank you to all our audiences for making the time. So very much just echoing Dharmi's address. But thank you, yes, thank you so much, and thank you to our live captioner Heather for her brilliant work, and also thank you to Tayyib, who's been behind the scenes doing all the technical aspects of this event. And just a quick thoughts, you know, Harriet's not feeling very well at the moment, so sending her all of our well wishes. And thank you to Code as well for helping us put this amazing event on, and Dharmi for your excellent work and on the report. Yeah, as Dharmi said, this recording will be available and free to access in the next couple of weeks. So it'll be available on our YouTube channel, so make sure to subscribe. But it will also be available on the Explore section of our website, which is a growing free to access resource where all of our kind of events and the knowledge that's shared by our brilliant panelists and the people that, you know, sacrifice their time to come on here and to chat through some really difficult and challenging concepts and topics. So that's all free to access, and so if you sign up to our newsletter, you'll get a notification once that's out. And then finally, we are a very small charity with big ambitions. So if you enjoyed this event as much as we enjoy hosting them and putting them on, then please consider donating using the donate button on our website. I think there might also be a link in the chat. But yes, so I mean, yeah, if I mean, yeah, if you're able to support in any way possible, we would greatly appreciate it, and it does go a long way. So thank you very much. Thank you, Dharmi. Thank you, Dzifa, for an excellent conversation. I'm excited to rewatch it. And have a lovely evening, everyone. Thank you. Bye.